everywhere again. And then if you could start talking, and I'll start sending this in the email form as well.
So that's what the other link is, so I can see the questions. Is it the other one that says live now?
Yeah, I'll send it to you.
Okay.
I added it to the chat in the other one.
Yeah. And I'm just waiting to make sure that I can, it just says your name on the screen there. So I'm just making sure it's actually going. Is it a different Zoom room we need to go to?
Negative. See, you're up there now.
Okay, looks like a lot of people are coming over. All right, good. Okay, I think we're here. So sorry for the delay, everybody. I guess we had a little technical difficulty. We're gonna give just a second for everybody to migrate over from the other link. Dr. Antevy is here with us today. We really appreciate him taking the time to join us. Hey, Jasmine, if you could you just click the gallery view so we can see Dr. Antevy as well, even though he's not talking yet. Okay, looks like people are starting to come over. So yeah, what I'm going to do, since we're running a little behind, is I'm just going to go ahead and get right into the updates. And as people come in, hopefully they'll get it sorted. Yeah. Go ahead and share out today's numbers. So hopefully you guys can see this. We're over 52,000 total cases in the state of Florida. When we drill down to Pinellas, we're over almost 1,200 cases, 75 deaths, a lot more hospitalizations. DR age range is very, very broad here. Still have a slight female predominance. Not sure where that is. We do have currently somewhere in the neighborhood of 35 to 40 people in our intensive care units, and another 120 to 130 people hospitalized within Pinellas County. So we still do continue to have a significant burden of disease here in Pinellas County. For those that want to keep up on the numbers, there you go. So like most people are joining over. Any questions about the numbers, guys, or what they mean, or what you're hearing in terms of testing or anything else? Not yet. All right. Good. So why don't we just, Peter, I don't want to hand it off to you until we've got a few more people here. So,
yeah.
Peggy, are you here today? Should I play some music while we wait? Looks like we're good. All right. So those are the basic numbers for today. You guys had asked last week if we could talk a little bit about the pediatric inflammatory syndrome that's going on. It's had a couple of different names so far, I think. What are we calling it now, Dr. Antevy?
Pediatric multisystem inflammatory syndrome.
Is there an acronym for that?
I mean, they're calling it like, MI-S. It has no good acronym, I don't think.
Oh, this is terrible.
Yeah, horrible, yeah.
So, Pinellas Medic, which case studies or reviews are you talking about? Can you be a little more specific? And then, okay, so is this a big thing? Is this a little thing? Are we seeing a lot of this, Peter?
No, it's very rare. If you look at the total number of cases that have occurred throughout the country that you just put up on the board, well, that was for Florida. If you look at the millions of people who have been infected, the number of children who have been infected is much lower than that. And then you're hearing about the big numbers of this inflammatory syndrome occurring in New York. They had over 100 cases. I've been kind of following around Florida. I mean, I've only heard of, at least in our neck of the woods here, a handful of them. I have friends where I trained in LA. They only have a handful there. I think you guys may have a couple on the West Coast, if I'm understanding correctly. Um, and it's very rare. I mean, I had made a couple of slides to show people what it looks like if you want me to share my screen, but
I think we did hear this morning, though, that there was a reasonable number of these cases in Paris as well.
yeah, I mean, that is true. It could be that people just are never associated or never linked it together, because today was the first time that we heard that from Pierre from Paris this morning. But I mean, most of us know this as Kawasaki disease, right? This occurs after the illness. We never knew what Kawasaki disease came from. There was always a link to it. But actually, I did some research on SARS and MERS, which are also coronavirus, as you guys know. And there was a paper from 2004, 2005 that actually looked at kids who actually had those coronaviruses. And I think the number was, I have the study up here. Let me just bring it up on my screen. They basically looked at those illnesses, and 72%, so 8 out of 11 children, developed what they call then Kawasaki disease after they developed the other coronavirus. So this has been described years ago. This study is from the Journal of Infectious Diseases in 2005. And again, so this is actually not an unknown phenomenon. And so the fact that it's happened again is not uncommon. I just think now that people are linking the two together.
And there also seemed to be a little bit of discussion as to whether this is a parallel to the cytokine storm that people were seeing when folks progressed from standard pneumonia to ARDS. Is that something that you put any credence in, or not really?
Listen, I mean, the fact that I haven't treated one of these kids myself personally, so, but from all the reports that we're reading, it just looks like a massive inflammatory response. But as most of you know, in Kawasaki's, the whole course of Kawasaki, let's start with that first, is that if you didn't treat Kawasaki's within the first 10 days, right? If you have a kid who comes in, the parents have fever, they have red eyes, they have a rash, they have like red lips, they have a big lymph node, all the signs of Kawasaki's, even if you sent that kid home, you missed it in day 1, 2, 3, 4, 5, it was okay. What happened with Kawasaki's is you had to figure it out before day 10. And why is day 10 important? Is because if you missed it and you didn't give them the treatment, which I'll talk about in a minute, you ended up affecting their coronary arteries, and you end up getting coronary aneurysms. And those kids had a chance of dying after the inflammatory process happened. And the treatment was aspirin and IVIG. And so with Kawasaki's, we knew that if we treated them within the first 10 days, they wouldn't die. And true today, very few kids die from Kawasaki's because the astute clinician will pick it up. There are very few cases that you'll hear about where the kid dies and then the doctors get sued for millions of dollars. With this particular case, I've been asking my colleagues out there, are you treating this the same way as Kawasaki's? And I think that the jury is out, but most people indeed are still giving IVIG. I've been asking my colleagues in the adult world, are you giving the adult IVIG for this massive cytokine response? And so far I've heard a big no, or I don't know. But I do think it's an inflammatory response. I do think the cytokines are at play here, but the jury's still out. So the CDC put together a working group. I think a doctor in New York put together a group so that all these cases could then be put into one single database. And I think as the time goes by and we get more specific details on each of these cases and how they were treated, then I think we'll have more information. But if it was me treating a child, I would treat them like Kawasaki disease. And I think that very few kids are dying of this. You'll hear on the news of the what five or so kids who have died, but most kids aren't going to die from this if treated well.
So I don't. You said you had some slides. Did you cover like the basic pathophys of Kawasaki's and what it is, or no?
Yeah, that's kind of what this shows here. Yep. I'm going to share my screen here.
Yeah, that'd be great.
Okay. Let me do this screen here. You see screen? Okay, so just let's kind of use this as a case, right? If a call comes in and you have a kid who has fever, and let's say that we're in the middle of flu season, and you know that type of thing. Obviously, this should be a startling picture to you. Number one, because of how the kid looks. You can see just kind of, you know, just laying back there. His eyes are kind of sullen. You can see the diffuse rash. If the pacifier wasn't in the mouth, you would probably see very red lips, red tongue. And these kids are just super irritable. So the number one thing here is they're tachycardic, but they're very irritable. So you'll never see a Kawasaki kid looking at you smiling. They're just miserable, and the tachycardia is out of proportion to what you would normally see. So look for tachycardia. So vital signs are very important here. Now, obviously, where these kids get into trouble is here. So if you now have this kid who's 2 years old, you guys know that normal, at least minimum blood pressure for a 2-year-old is 70 plus 2 times the H, that's 74. So this is low, right? The kid's hypotensive, he's tachycardic, he's tachypnic, and he's febrile. You know, obviously this kid is in danger. And so what you would do clearly here is you would get a line in and you would give IV fluids. That's kind of the one thing we can do in the field to really help this kid out. Obviously, I'm not sure if you guys have antipyretics for these children, but I think where most people go wrong here, especially when we get into flu season, is that most people miss the hypotension part. Most people will attribute the tachycardia to the kid screaming, and they don't want to put the kid on a monitor. So when you look at all the data from the sepsis and pediatrics and EMS, very few kids end up getting a blood pressure. So those of you out there hopefully know how to do a palpable blood pressure, which is basically just putting the blood pressure cuff on the kid's arm, putting your finger on the radial artery, and then inflating it, and then letting that pressure out until you feel a pulse. And that pulse, that pressure at which you finally feel a pulse, is the palpable blood pressure. So you don't need a stethoscope. You should just be able to do this with your 2 fingers. And at least get a palpable blood pressure. Unfortunately, again, I don't know, Angus, if you guys track the number of blood pressures that are missing in children, but across the country, it's pretty high.
Yeah, not surprising, right? So before you move on, let me just ask you a question for the sake of the folks watching. So our Antevy book says normal heart rate for this kid is 85 to 140. This kid has a heart rate of 180. How concerning is that? You mentioned like some people might just tack that up to crying or whatever. His blood pressure is 70 palp, and the lower range of normal, according to the 2-year-old page in the book, is 75. So like,
Right.
from your standpoint as a pediatric ER guy, is this like scary bad vital signs or like a little bad vital signs?
Well, these are not a little bad. These are bad because once a kid is hypotensive, they're already at they're circling. And so why this is bad is because kids, unlike adults, they maintain their blood pressure until they don't maintain their blood pressure. And then, all of a sudden they they kind of go out on you, and next thing you know, you're managing their airway, and most people then will go right for intubation, right? And then you screw things up even more because I'm not sure if you guys use RSI, but if you have a kid who's hypotensive and you haven't managed the hypotension part of it, and you go in and you try to, and then you paralyze the kid, you take away all their negative pressure, they don't feel their right heart, and next thing you know, they're going to cardiac arrest. So I've seen many people make the mistake of not addressing the vital signs with respect to the blood pressure and the heart rate. You know, a kid like this, if you can't get an IV quickly, give them an IO. And give lots of fluids fast. Now, obviously, after every bolus, you're listening, you're feeling, or you want to feel the liver to make sure that you're not, overloading these kids and making sure you're not missing some other cardiac issue. But for the most part, I think people miss out on giving the right amount of fluids. I harp on all the time. If you ever kind of want to drill down and kind of have a little fun with this, get on the mat and give everyone a case, and then you say, okay, the kid's 70 over PALP, and watch what happens. What will happen is they'll say, okay, I have an IV in place, and you'll say, great, and then they'll say 20 cc's per kilo. Now the danger is to stop there, right? What I would say is, show me. And when people 99 times out of 100 want to give this kid 20 per kilo, which is 240 mLs, they'll do something like they'll have a 24 gauge somewhere, hand, right AC or something like that. And then they'll do this. They'll say, oh, I'm going to pressure bag, which is not good, right? This kid needs 20 cc's per kilo in 10 minutes, which unfortunately now most of us only have the push-pull. And if you've never done push-pull lately, I'll guarantee you'll never do it, because what you're going to say to yourself is, oh, I'm right down the street from the children's hospital or from the local ER. And then where that's wrong is they're just as bad. So this is scary bad for me, especially in someone who thinks that the hospital is where this kid needs their care. We need to fix this kid. We need to get their heart rate down, their blood pressure up. And if you're going to manage the airway, I would advise, just doing it with a BVM at first. If the kid goes out on you, OPA BVM, and then I would use the supraglottic after that. But here it's more hemodynamics than airway every single time. So I'll stop there if anyone has any questions on that.
So this kid, it seems like you would describe this kid as being really into decompensating shock kind of a scenario at this point, by the fact that he's already hypotensive, and we know that kids maintain that for so long, then they crump all of a sudden. Can you do me a favor, because you said something that's really important that I'm not sure is in the normal thought process for these guys, and talk about what you meant by palpate the liver?
Oh, okay, yeah. Well, what happens is that every now and again you'll get a kid who, usually they're younger, but they come in, they're hypotensive, and everyone's first inclination is just to fill this kid with fluids. And I would say that over 90% of the time, probably even 99% of the time, you can give the kids fluids and there's never a problem, because it's not really a cardiac problem, right? They're not having kind of right heart failure, if you will. But then every now and again, you give the 20 per kilo and the kid gets a little worse, right? And so they say, let's just give more fluids, boom. So there are some clinical findings that would allow you to differentiate between a kid who just has an empty gas tank, needs more fluids, versus someone who has a bad engine, cardiomyopathy, somebody with heart failure, like a CHF, right? And if you have heart failure, the heart is not pumping blood forward, and so it's backing it up. It's kind of being backed up. And so after every time you give a fluid bolus, you need to listen to the lungs. Is fluid backing up there? You need to feel the liver, because if the heart is not pumping fluid out, then the liver is just going to become enlarged, and you're going to get back up there. So you have to feel for the liver. And so if you had an ultrasound, obviously we could look at the IVC with the ultrasound if you're looking for fluid status. But my preference is to give a lot of fluids, with the caveat that you should always, after every single bolus, you should do a clinical evaluation of that child or adult for that matter. So that's kind of the explanation of the liver just backing up fluid from the heart.
Almost like a poor man's ultrasound of the vena cava for these kids.
Exactly right. Exactly. Again, very rare. I'd be more concerned about that for a kid who's got like a coarctation of the aorta. Those kids present on day 10, right, where their PDA was saving their life, basically because it was a conduit. And all of a sudden on day 10, the PDA closes, and now all of a sudden they go into massive shock. And those kids, if you just fill them up with fluid, they'll die on you. So again, not that common, but I will say that I'm always about the bedside evaluation. I think the true EMS professional is, even in the most chaotic of situations, is always doing an evaluation of the child, not just visually, but if you can, looking at their cap refill, feeling their pulse, is it stronger after your fluid bolus, looking at their mentation and so forth. I'm a big fan of going to pressors earlier on children now than I ever used to be, because I just think that kids need that blood pressure support. And I've been wrong. I mean, I've been doing this for 21 years now. I can tell you that early in my career, because that's how we trained, it's always give fluids, and then finally end up at pressors. I don't do that anymore, especially with the sick asthmatic, just another great example, where if you RSI a child who's hypotensive, they're gonna die if you don't address their fluid status and their pressor status. And so I'm a big fan. I'm not sure if you guys do this, of push pressor epi, and so I will go early to a pressor in a kid like this while I'm getting the fluids on board, and I'm not going to surely wait for the hospital to do it for me, because they're maybe just as bad as being fearful of pressors, and the kid ends up in the ICU, and by then it's too late. And so what most people, Angus, end up doing with these kind of kids when they go bad is they do this with the BVM, right? And all of a sudden you're overinflating the lung, it's squeezing down the heart. So you have a kid who is hypotensive to begin with, not perfusing their brain to begin with, and then we kill them with the BVM. And so I would caution everybody that knowing how to BVM a child and not doing it aggressively is probably your biggest is your biggest win. And address vital signs before you intubate if you're going to use paralytics on these kids. So.
We're getting off on tangents, but just because it's important, my folks know that when we talk about the difference between a clinician and a technician, that's exactly the scenario we use to illustrate the point, to understand what hemodynamic impact switching the patient to positive pressure ventilation is going to have. And my folks also know that I sort of argue with our local medical control board about how early to do pressors and folks. So they want us to do some fluids first. For my folks who are watching also, we do have a draft push dose pressor protocol, which will be getting added in probably this year. Is one of the things that Dr. Antevy was just talking about. So we do have one or two questions here in the chat for you, Peter, before we keep moving, hopefully, with the case. You mentioned that an IO would be appropriate in this kid. So is this kid very sick? I think is yes. And would you, if you were drilling this kid, would you use lidocaine?
That's a great question. So we've been down this path, and I'll tell you, first I'll answer another question and I'll get to this answer. I'm a big fan of the femoral IO, the distal femur IO in cardiac arrest only. I think it's a better place. The bone is bigger, it's thicker, it's easier, you can't miss it. And so we have moved kind of strictly to the femoral IO, except when you have a kid who's awake. And why not give a femoral IO to a kid who's awake? Because if you look at your own distal femur, there's a whole bunch of tissue you have to get through to get to that bone. And the plastic hub of the EZ-IO, as it's spinning in the drill, when it touches your skin, it creates a burn, basically a plastic burn on your skin. Doesn't feel good. And so we found ourselves loving the femoral distal IO, distal femur IO so much that we ended up doing it on live children who were hypotensive, and boy, did that not work out well. So I would say in a kid like this, if you're going to do an IO, right, I would go proximal tibia, just like you would have, just kind of how we learned in the past. There was a recent study on the proximal tibial IO where they looked at a bunch of cadavers, right? So kids who didn't make it. And obviously, what would you expect in kids who didn't make it? That either they were just dead and they had no trance, but it turns out a majority of those kids had maybe half of them. I have to look at the data exactly. It's been a while, but that proximal tibial IO needle went around, was nowhere close to the bone itself. When you look at how thin that bone is, especially in a kid this age, it is a skill that you really need to kind of understand, that you can't just zip it in. And so the long-winded story is that I would say this kid gets a proximal tibial IO from me. And if a kid goes in cardiac arrest, they get a distal femur IO, which is, and we're actually collecting our data. There's 0 publications on distal femur IOs in children. We're probably going to be the first one to look at it, but I can tell you anecdotally, we're never going to go back to doing that specifically in cardiac arrest. Hopefully that answers the question.
Awesome. All right, we've got to keep moving.
All right, so you want to keep going with the case? All right, so basically just a review of what this inflammatory process does. And essentially, what's interesting about Kawasaki, it is all inflammatory. Let's start with the top, the bloodshot eyes. Very different from the kid who's got viral conjunctivitis in that there's no drainage here, none. Because it's all just inflammation of the small capillaries. Same thing in the tongue and the lips. The hands also, a lot of capillaries in the hands, swollen. The feet, and again, the rash is just inflammation. And interestingly, if it's a boy, and you look at the tip of their penis, it's also inflamed red. So all inflammatory stuff, and then of course the inflammation we worry about, because we don't really worry about any of this on the screen. What we worry about is the heart. And so again, we mentioned this before. This is kind of the shitty name they gave to this. And you can see here the clinical findings. They all have a fever. Most of them need oxygen. Most of them are finding to be hypotensive. These are these sick kids. So again, give them oxygen, give them fluids, and give them a transport. And then you can see that some of them have a number of these other really just inflammatory findings. Then when they get to the hospital, they all need an echo, EKG, chest x-ray. We do an abdominal ultrasound looking for things like colitis, ileitis. We look at their gallbladder and so forth. And then you can see they'll do CT. This is not really for us in EMS. And then there's just a whole bunch of labs that are all kind of inflammatory labs that need to get done. But we mentioned this already. This is all very rare. There's a good likelihood that none of you will ever see this. But when you miss it, and you miss a hypotensive kid, forget about inflammatory syndrome. Most people miss sepsis in general because it just doesn't look like anything bad, because no one ever checked the heart rate and no one ever checked the blood pressure. Just one last clinical pearl, like a pro tip. In the ED, what I do is when the kid's screaming, I put on the leads, I close the curtain and I close the light, and that monitor is out in my workstation. And when I leave, everything kind of comes down and I see their true heart rate. I would recommend that you guys at least have the kid, put the leads on the kid, put the monitor on the kid, and then try if you can, to kind of hush them, quiet them, and you can get a true heart rate. Don't tell yourself that this is just a screaming kid who's in a moving ambulance, and that I can't feel the blood pressure because I can't hear the stethoscope. Don't do that.
Awesome.
And that's all the slides I have on this case. So.
Cool. So a couple of questions here, and maybe I'll just throw in one or two things that I remember about Kawasaki's from before. So the mnemonic, or the saying in med school to remember Kawasaki's and why it's important, is that Kawasaki's kills kids' coronaries. And this is, for those of you with kids that are watching, this is why if your kid has a fever, the doctor says, hey, has it been more than 5 days? So the reason why they ask you about how long the fever's been, to see if it's been over 5 days. And if you have a fever for over 5 days that's otherwise unexplained, you have to start thinking about Kawasaki's. Now, in the chat here, Peter, there's a couple of questions. So the one person goes, so lidocaine? For the
Oh yeah, that's right, lidocaine, yes. I'm a big fan of lidocaine. I think that in the awake person, giving 0.5 milligrams per kilo lidocaine, I think that should just be in your protocol. It shouldn't be in the cardiac arrest protocol. So the answer is yes to lidocaine, max of 40 milligrams to the adult. Yeah.
Awesome, thank you. And then so the next one is, so if this inflammatory response / Kawasaki mimic is COVID related, do you see any variance in symptoms or time frame for a COVID mediated version versus a naturally or wild type Kawasaki's? It sounds to me like this would be later in the disease course than maybe the wild type one. Because that in that case, you sort of see all this in the first 5 to 10 days of the fever, but in COVID, this may be sort of the second wave of disease. Is that what your impression is?
No, the way I look at it is, and I trained in LA where it was like Kawasaki, heaven over there, right? We just saw a ton of it. We never really knew what caused the Kawasaki. So we would always ask the parent, did little Johnny have a virus a month ago or a few weeks ago? And they were kind of all hem and haw, but by the time the Kawasaki picture came up, they had the fever going and everything. So in this particular case, these kids are also getting sick, that people think 3 to 4 weeks after the initial COVID. So if you test them by PCR, they're going to be negative. You got to test the antibody. You got to get a quantitative antibody test to see whether or not they have COVID antibody. So where people have missed this is they say, oh, you look like you have this syndrome. Let me do a nasal swab for COVID-19 and it's negative. Well, yeah, it's going to be negative because the COVID wasn't this week. It was probably an asymptomatic case that you had a month ago. So I would kind of harken back to what I said earlier, where the cases of Kawasaki's from the SARS virus from years ago, from 2001, it all just presents later, just like the Kawasaki's that we've always known presents later. No one's ever known what caused the Kawasaki's. We never had an idea of that.
That makes sense. Because to me as an ER doc, I never know what the thing was a month ago that happened to the kid. I only know why.
Correct. And most parents just make it up and say, yeah, I think they were sick. But, I have a nephew who has had Kawasaki's twice. So you can imagine, and we have no idea whatever happened. We end up running all these viral tests. But remember, you're not going to catch the virus when the Kawasaki shows up. So now for the first time, we have this COVID ELISA antibody. So now, I think this is going to be great information that this is definitely the result of a virus that happened about a month ago, is what I'm thinking that this all has to be.
Wow. So in what you're saying there is that actually the clinical course of this thing and associating it with COVID or SARS-CoV-2 virus is actually helping us to maybe better understand Kawasaki's in the first place.
1,000%.
Sort of elusive kind of a disease that all of us learn about, but not very many of us see in the non-pediatric world. That's super impressive to see that sort of side track to the whole thing. Another question from the field is, so if we see or think about the patient in front of us might be Kawasaki looking in the field, should we assume the cause is secondary to COVID-19 right now? And I think you probably agree the answer is probably yes, because
100%.
given the season of the year it is right now and what else is going on in terms of viral illness out there in kids. But there's a follow-up to that, which is likely related to whether they feel like they should take lots of PPE precautions with that patient. That is that's a super question, because likely they may not be contagious anymore, but my answer would be absolutely yes, go to full PPE if you see this. What do you think?
Right. But listen, we'll be talking about this in a year from now and saying, of course, these kids were not infectious with COVID-19, and you'd be right. But I'm 100% with you on that. I mean, you'd be silly to say to be cavalier, even though we're talking now and we're saying, wow, these kids have fever, red eyes, red lips, but they're not infectious. No, they're not infectious with COVID-19, but you'd be stupid to take a chance on that. I surely wouldn't do that. Yeah.
Okay, so here's another follow-up question, which is they want to know why it takes such a long time before this sets in following the original viral or bacterial infection. I guess the one thing we didn't sort of talk about is the actual, like, what is the mechanism of the inflammation? So I don't know if you can sum up the vasculitis process real quick, or whether that's...
Honestly, for as many hundreds of kids as I've seen with Kawasaki's, this has all been an enigma. Nobody ever knew what causes this or why it's caused. All we knew is to treat it with aspirin and IVIG, make sure we got the echo. And so I think that some smarter people than us are going to have to figure out what is it about those particular children who get weeks later an immune response where their immune system goes haywire against their vascular bed. And I honestly, I don't have no idea.
Yeah. So for the folks watching, it's a vasculitis, or an inflammation of the small blood vessels, sort of post-viral or post-infectious, but the exact mechanism we don't really know.
Right, and that's why these kids get abdominal pain, right? So that these kids get a vasculitis of every small blood vessel in your gut. You got a lot of those, and these kids are basically having gut ischemia. And if you've ever seen a child come in with ischemic gut, these kids are like in pain, like writhing in pain. So pain out of proportion to anything that you ever would imagine in a child. And I'll never forget a case where I had a kid literally come in by EMS, and she was like 10, 11 years old, and she was screaming so hard, people thought she was like a psych patient and so on. She was having mesenteric ischemia or gut ischemia. So look for that with this as well. Abdominal pain is a big one here as well.
Wow, that's super interesting. So it's actually the same presentation as like our old people that have mesenteric ischemia from their atherosclerosis.
That's right.
Crazy pain out of proportion.
That's
really
right.
Interesting. All right, so there's a couple other questions in the chat room that want to kind of switch the topic to testing.
Yeah.
Cool talking about that a little bit?
Yeah, I love that topic.
Talked about it, but maybe this is a good opening question. Is Josh says he follows you on Twitter, and he saw the most recent IgG was positive, and knows you were back and forth on it, and he wants to know, do you think you did have COVID after your most recent tests?
Yeah, the answer is yes, and I'll tell you why. I was sick as shit in January. I was overseas. I was on airplanes. I was flying everywhere, and I was in LA for like 8 or 9 days, and I almost had to check myself into the hospital. There was one night that I literally I couldn't sleep because I could barely, it wasn't that I was hypoxic, at least I don't think that I was, but I could not stop coughing. And, and listen, knock on wood, I don't get sick. And so I've taken a total of 5 tests. 3 of them have shown IgG. The most recent one, which is an EUA, FDA EUA approved test. So this week, actually tomorrow, I'm going to be doing an ELISA test. I'll be getting quantitative antibodies on myself, and we'll see what happens. I don't know, but yeah, answer is yes. And thanks for following me on Twitter. I appreciate it.
There you go. So that was a good lead into, let's talk a little bit about the different types of tests out there. And this is something I wanted to talk to my folks about today too, because they know that we're getting ready to do some serologic testing on them. And we've been doing, obviously, nucleic acid testing on them as we go through this. So maybe I'll try to start to describe the difference between those 2 tests and what that means, and how they might be interpreted, and then see if you agree with me. Maybe that's the easiest.
Yep.
The nasal swabs, and in some cases the saliva tests, that people were hearing about. Those are what are called nucleic acid amplification tests, or PCR, which stands for polymerase chain reaction, where they basically take a swab from you and then they put it in a machine that runs what's called a PCR, where they are looking for certain sequences of the virus's RNA. And if those sequences are there, they'll get amplified or copies made of them until the point where you can actually measure those or show positivity. But if that particular sequence of viral RNA is not there, there won't be anything to be amplified and it'll show negative. So that's, how did I do? Was that a pretty good description of what a PCR, nucleic acid amplification test is?
Yep, exactly, perfect, yep. I like to call those direct tests. So you're directly looking for the virus, and I have the image on the screen here that you just mentioned.
Oh, awesome. So that's the kind of test that we all started with because that's all we had. And there's some limitations to that test. Limitation one is false negativity. So there's some percentage, and you've probably seen articles in the news about particular tests and what their false negative rates were, and particularly related to the one maybe that they were using in the White House.
Which is this one. This is the one right here.
Your screen's not up right now, but
Oh, it's not. Oh, I'm sorry. Here, okay, I can do that.
you're the Abbott test.
Yeah. Okay. Yeah. Well, as you're talking, I'll share my screen.
There you go. So that's yeah, perfect. So that's a picture of the Abbott Now ID Now machine, and there's other machines that do that. Uh-oh, we went to a black screen somehow. We lost your.
Okay, I'll stop the share and I'll try it again.
We saw like a quick picture of it, and then it went dark.
How's that?
Yeah, perfect. So this machine here in the bottom left corner is the Abbott ID Now machine. This is the one that they showed at the press conference at the White House, and this is the one that people have been writing news articles about its lack of sensitivity, essentially. The thing with the direct tests, or the nucleic acid amplification, or PCR tests, however you want to call them, is that they are generally very specific, meaning they won't turn positive for other viruses, but they are often lack as much sensitivity as other tests. So they may miss cases is what it comes down to. You may have false negatives with them. So that's what we've been doing because that's kind of what we had. And there are now versions of those tests that take an hour to run, or even a few minutes less than an hour. And then there's versions that take a lot longer than that. And the real holdup with those tests is, even though it might take 6 hours of processing time to actually do the test, is the labs are only have so much capacity every day to get them done. So that's the first kind of test, and we've all been struggling with those over the last few months. And now more recently, we've begun to get what are called serologic tests, or indirect tests, which test for antibodies or markers that you have mounted an immune system response to the SARS-CoV-2 virus. And so there's sort of a strange story with the antibody test that starts back in March, when the FDA put out guidance that said companies that are making these things can go ahead and rush them to market without meeting all the usual standard checkpoints along the way. That resulted in something on the order of over 100 companies bringing these little bedside test kits that you put a drop of blood on to the market. Many of them based on very small sample size validations, and many of them somewhat suspect. You may have heard some stuff in the news about ones that Italy ordered from China that they sent back because they didn't work. So there was a lot there. But basically, these are going to test for either an IgG or an IgM antibody to SARS-CoV-2 virus. And for just a quick reminder, IgM is the one that turns positive early on, and I remember that in med school with.
Sorry, I was gonna get you that. Here you go.
Perfect. Oh, what a great picture. So IgM is your first antibody, and basically I always remembered it like M for immediate response, which was sort of counterintuitive because you want to say M for memory response, but it's actually not the one that does memory. It's the one that does immediate. And then IgG, which is hopefully a longer term antibody that sticks around and provides protection going forward. And as you can see from this graph that Peter put up, both of them take some time to turn positive. The IgM tends to come earlier than the IgG, at least. And again, when I say to turn positive, it may not be that you haven't made them yet. It may be that there's not enough to test positive for. So when I say turn positive, I'm talking about the test turning positive, not necessarily your body just starting to produce them, because your body produce a certain amount of them before you would show positive. But basically there's a time course for these things. And so the serologic test is useful to know about prior infection and therefore make conclusions about the overall level of a virus in a community, and potentially conclusions, assuming that IgG is actually protective, about long-term immunity. So like if you've had it before and you mount an IgG response, are you protected then from having it again? So maybe I'll stop there for a second, let Peter chime in on his thoughts on these things.
Yeah, we've been through the same thing that you're talking about here with those bedside tests. Here's what we've come to the conclusion. And we actually were the ones who validated the CellX test. And lo and behold, just like Angus just mentioned, we actually tested 31 known PCR positive patients. So these are people who came to our study site with their PCR results, said, I had COVID. And in China, they had done their own validation, and guess what? They came up with a 93 out of 100, or sorry, 93% that this test would pick those people up. We found only a 68% sensitivity. So there's a couple of questions here. A, is it possible that the test over time, like, so if you mount an IgG response and over time, and remember, a lot of these people that we tested were 45, 50, 60 days out from their COVID. They were sick 2 months ago or a month ago. You know, is it possible that the test, as you see on the screen here, the IgG levels go down and therefore the test doesn't pick it up anymore? And so we also feel that this kind of 15-minute antibody test, especially when you're dealing when we know that only like 1 to 2% of the people actually have coronavirus in the population, these tests function even more poorly, and their positive predicted value, meaning that the odds of it showing someone who has the virus when they truly do have the virus is very low at this kind of prevalence rate. So I don't want to get too much into the details here, but these tests are not a test that you should be making any decisions on. So what we're doing now, we're testing 5,000 people 3 times at 0, 6 weeks, and 12 weeks. And what we found in Coral Springs and Davie so far is a 1% positive antibody rate. And we're going to test those same people in 6 weeks from now, and then in 12 weeks. So what we've done is we are now doing the bedside antibody test, the indirect. We're also now doing, instead of the nasal swab, we're doing the oral swab, which is the direct test for PCR. And now what we're going to be adding in is the ELISA test, or this, the actual, what I think is the best test to do if you think you have had it, which is you send your blood to the lab, they get your result in 1 to 2 days, and they actually measure the IgG in your blood if you have it. The only problem is, so you have three different things: the rapid, the direct, and then the ELISA, which is the antibody test I just talked about. Even if you have antibodies, we don't know what that means. Does it mean you're protected forever, like Angus just mentioned? So I think that we have a long way to go to understand, A, how to use these tests. But at some point in time, we're going to have to say, if you have antibodies, we may tell you you're good. You're not going to get sick again, but no one will tell you that just yet. So a lot of data still needs to be done, to be collected. And we're part of that process. I know you guys are looking at that same exact process. But if I had my crystal ball, I would say that that the antibody test, where you're actually looking for the actual antibody in the bloodstream with the ELISA test, the quantitative test, I think will be a way that people in the future from home will be able to send in your blood and get a result. So we're far away from that at this point in time, but we'll see where this all takes us.
So yeah, I agree with everything you just said, and we had a plan to do broad-based serologic testing of every first responder, whether they were fire-based, EMS-based, or law enforcement-based, multiple times over the course of a few months. When we started seeing the performance characteristics of the tests, we sort of pulled back on that plan. And we've decided to do a validation study before we proceed with that. And what you mentioned about the ELISA is exactly what we're going to do. We're going to take 30 sort of people who are asymptomatic and we think haven't had it, and see what the little bedside test shows, and on that same patient run the ELISA and see the concordance. And then we're also going to take blood from 30 known COVID patients in the hospital and do the same thing. And we're actually also going to likely look at the time course between diagnosis of infection and turning positive on the bedside, as well as the level of IgG on the ELISA, because we have a biobank of blood samples from all of our COVID patients that we're going to do that on.
Right. So that's awesome. I'm so glad you guys are doing that. Listen, if somebody was asking me to come to their house and test them for COVID, the algorithm I would do today is I would do the finger prick blood test just to get that out of the way. If they happen to turn positive, I would say, hey, let's do an ELISA test. If they turn positive for IgG, if you turn positive for IgM, I would do a spit test or a nasal swab or whatever, one of the PCR tests, the molecular tests we talked about. And so, you know, I think that there's a little bit of an algorithm. We've created one. I'm happy to share it with you guys. I'm sure, Angus, you guys already have something similar, but every person has to kind of go through the algorithm the right way. And once we have all this data, the data you collect, Paul Banerjee is doing a 10,000 person study with ELISA. I think in the next month or two, because remember, my prediction, we're in this for another year, right? A lot of people are going to get sick. People are going to get nervous. Am I immune or not? There's going to be the need for people who actually know what they're doing on the testing side. And you're going to see a lot of companies kind of coming out there trying to do people's tests and on the internet and all. It's going to become crazy. This topic right here is going to be all encompassing in the next year, because people, once this shit spikes, sorry for my French, once it spikes, you're going to get a lot of people who are going to want to know what their status is. And you're going to have people like you, Angus, and your department to say, this is what we think you ought to do. And that's kind of where we're trying to be those people here in South Florida. So.
Yeah, I think it's really interesting. And somebody in the chat mentioned the SIDREP viewpoint about testing.
Right.
I previously given them the SIDREP link, but I'll give it again. You could just Google SIDREP, CIDRAP. The latest post there is exactly about this, about having a logical, sensical, rational testing approach, which is something that we don't necessarily have at a national level at this point, let alone at a local level. I think, we're still kind of muddling through, doing the best we can with what's available, but certainly, there's still supply chain issues all over the place with testing and reagent. There's issues with things, getting sold that aren't FDA approved. There's all sorts of issues. One thing I want to just emphasize, Peter, that you mentioned was the relationship between positive predictive value and prevalence of a disease in the community. Do you have a slide of that in here or no?
I don't have that here, but I do have it somewhere else. Let me unshare my screen real quick, and I'll show you.
I got one real quick. Pulled up.
Yeah.
There. Let me just get it pulled up.
Let me find it here.
Oh, here we go. I got one. I don't know if you guys can, hopefully you can see this. This is just a quick one from MedCalc. And there's a bunch of math type stuff there, but basically what this graph is sort of sums up the point that Peter was making, which is that the performance or what you can say about a test result in terms of what it means for your patient sitting in front of you is impacted by the level of prevalence of the disease in a population. So you can see here that if everybody has the disease, then the test performance is going to be much better because there's many more people for it to find. But if nobody has the disease, it's going to be very hard for that test to find the disease when there's so few cases. And that's a very sort of simplified version of the relationship. But I think it's important to note that, we are seeing across really the country, the maximum seroprevalence rates out of New York are like, what, 15%, 20%. I think I saw one that had it a little higher than that. But down here in Florida, the range that we're seeing in initial testing is anywhere between 1% and 8% maybe max, and that's in like the hardest hit areas. Most areas are sort of in the 1% to 2% range for seroprevalence, which means it's very hard for these tests to perform well, and any lack of sensitivity or specificity is going to be magnified by that. Hopefully I explained that right, but or in a way that can be understood. But I think it illustrates the point that in a disease that's relatively rare in the population, that the tests kind of have to be better or work harder to identify cases.
Well said.
It's a good point to bring up when it comes to trying to have a rational testing.
Once we're at like 33%, then those tests will perform phenomenally well, right? So a good scenario where they would work well and where I would use them is that nursing home that suddenly has 3, 4, 5, 6 cases. Then that if you take that test into that nursing home, and that's what the CIDRAP paper, the SMART testing, talks about, where you have a high prevalence in that environment, these tests will now work well, and the positive predictive and negative predictive value actually means something in the 90% range once you're at the 30% level. So that's what's called SMART directed testing. Yeah.
I would agree, except for the fact that these tests the antibody test can take a long time to turn positive, 5, 10, 20 days.
That's
and
true.
Outbreak mitigation at a nursing home, I really need to be doing direct testing to get people isolated. So there's
right. My only feedback to there is that make sure you're doing a test that gives you a 24-hour turnaround time. The state of Florida is still doing testing that gives you 7-day turnaround time. So we've abandoned that, and we've now kind of contracted with our own people, and we have a 24 to 36-hour turnaround time for those specific tests. Right? I agree with you on that.
We're working with our hospitals here to have it done at the hospitals. I mean, I work at the big hospital in the area, and we're not the only hospital that has the 48-minute machine.
Right.
A lot of those spread throughout our community. It's a matter of supply chain for resources, for the reagents that people have heard of on the news. But for my opinion, there's a real need to be able to rapidly turn around the direct testing to get an outbreak in a nursing home under control. Now, it's interesting that the state is testing every single nursing home resident and staff over the next couple of weeks, which will provide us a lot of information about the baseline rate of infection in those states. It won't necessarily, it'll help a little bit, but it won't necessarily help mitigate outbreaks on an ongoing basis. It might help us catch a few right now, but it'll tell us more about how useful what the seroprevalence might be expected to be, and how useful those other types of tests might be in that population. So a lot remains to be seen about what's the best way to go about this. But I think I got a question just this morning about somebody wondering if they could use the bedside rapid finger stick test to screen people on the way into an EOC activation. And my answer is no, you really can't use this test for that, because it doesn't, even the IgM, as in the slide you showed, doesn't really turn positive till 5 to 10 days in. And the peak positivity rate for IgM is like 21 days into illness, by which point you probably are recovered, unless you got the severe disease, and you are most likely not even contagious anymore. So there's a lot of limitations here, and a lot of false information about testing, or lack of understanding about some of these really slippery issues. A couple of other questions here. Josh asked about previous SARS. He said, previous SARS, you have about 1 to 2 years of antibodies, right? So it wouldn't necessarily be the same antibody as the SARS-CoV-2 antibody. There may be cross-reactivity. I'm not sure we know the answer to that 100% yet. Hopefully the test is specific enough that it's this version of the SARS virus. Have you heard anything about cross-reactivity with previous folks who had SARS or MERS?
Yeah, so how these tests are made, I presume he's talking about the rapid antibody test.
Yep.
And so when you talk to certain companies, the antigen that they're using in the test should be from the SARS-CoV-2 virus, and those spike proteins look very similar from SARS and maybe even other coronavirus in general. But the better tests are using the antigen from the SARS-CoV-2, whereas it was reported early on, the test coming out of China, we're using the antigen from SARS-CoV-1, which is SARS. And so the better tests shouldn't have that cross-reactivity, but when you look at the package insert, they all say that you could have cross-reactivity. So listen, I've called these manufacturers, I've spoken to the scientists, and they swear to me up and down that they're using the right antigen in these tests so that the antibody that's in your bloodstream will pick it up as it's going across this immunoassay. But I would say to you that yes, there probably is cross-reactivity, but you would have to presume somebody had a coronavirus in the last year, or they've had SARS in the past. And so when everyone's having coronavirus and you get a positive test, again, you have to presume it's probably coronavirus, but nobody really knows the true answer to that, in my opinion. I've heard so many different answers.
Yeah, I'm hoping some of the work we're getting ready to do will help tease some of that out.
Correct.
But we're in process of pestering the IRB today to approve us. So Shane, who is one of our firefighter paramedics who also works in a pediatric ER still, I believe, asked, what's the pathway that you are using for the pediatric ER environment, and what tests are you using for them?
Yeah, so actually we just put one out, and I'm happy to send it to you. But basically, it's just recognition, and then it's what we did for Kawasaki's for many years, which is we get all the inflammatory markers. We're probably going to add on ferritin now because we never really got a ferritin before. But, CRP, ESR. We do a urine. If you remember what I told you before, that in boys and even in girls too, you get the tip of the urethra gets inflamed. Again, small blood vessels there, and so we actually have the kids pee into a urine. But normally, when you do a urine specimen, you have either you use a catheter, which you cannot use because you're looking for the inflammatory cells. If you use a catheter, you're not going to find it. So with Kawasaki's, or with this disease in particular, if you're going to get a urine, it has to be not a catheter, and you cannot tell the kid if they're older, to pee in the bowl first. It's got to be the first urine coming out in order to catch that. So, urine test, the typical blood test, EKG, echo, chest x-ray, abdominal ultrasounds. But, and again, all of that was what I posted here. But the bottom line is you have to recognize that this is what you're looking at, because I guarantee you'll be in the ED during flu season, and 10 out of the 20 kids in front of you are going to have a fever, and they're going to have some, other symptom. And you're going to say, nah, it's not 5 days yet, or I don't see a rash. But it's going to be very confusing to a lot of people. But I would say just keep your eyes open. They're not all going to be as classic as you think they're going to be. And this is missed by a lot of doctors because they're subtle. So just be careful. Just keep your eyes out. Be a clinician. Don't worry about the lab tests, I would say, my opinion.
There you go. Let us know in the comments if that answered your question. Chief Tedesco, I just posted the link to the CIDRAP testing viewpoint in the comments if folks want to look at it. It's on my list to read again through tonight and make sure I've captured everything out of it. Chief Tedesco also asks if there's any chance that you would share those PowerPoint slides with us.
Absolutely. Yeah, absolutely. And also, I'll share them with you, Angus. You could take everything I have, right? And also, if you look at EMS World and then you type in my last name, I did a webinar with a public health doctor, Rick Pescatore, which is a brilliant guy. He kind of carried the load on that webinar, but that entire slide deck is narrated. It's available on EMS World for viewing. I'll give you the entire slide deck and you can do what you want with it. Absolutely.
Awesome. Thanks.
Sure.
We've been going on a little over an hour now, and we've still got about 50 people watching. So thank you guys for sticking in. And let's any other questions or comments folks want to put in the comment, we'll try and address over the next few minutes, and we'll then try and wrap up because I know Dr. Antevy has lots of important things to do.
That's good. It's all good. This is fun for me. I was looking forward to this actually.
Yeah. We've been doing these a lot, and I think we're going to try and continue to do them even after we're done talking about COVID in a year or two.
You know, it's funny that at the same time that you asked me to do this, I got calls from San Antonio and a couple other places. It turns out that this type of learning that we've become so used to now on Zoom is what's going to be the normal. And I think people are used to it, and I don't have to leave my house if I don't have to. And so not a bad idea.
I think we're going to refresh everybody on PHTLS over Zoom this summer and fall, which should be interesting. So everything but the testing will be on Zoom, I think.
Yeah, we just created the whole Antevy course. We linked up with a company called Prodigy, so we can do the hands-on. I'm not going away from hands-on. You still got to know how to draw medications up and push pull and all that. But we've also done the same thing. So.
Oh, yeah, just for any of our viewers thank you for saying those words again. For any of our viewers who don't remember what push-pull means or think of it as something else like using a three-way stopcock, what are you talking about when you say push-pull bolus?
Yeah, so let's say I'll just give you a quick example. A 1-year-old kid is 10 kilograms and he needs 200 cc's, right? 20 per kilo times 10 is 200 mLs of normal saline. In order to get that kid quickly, you have a few options. If you're in the hospital, you can dial it in to 1,000, right, or 999, and it still won't go in that fast. You can do a pressure bag and squeeze it. Still won't go in that fast, especially through a 24 gauge IV. So what we recommend that you do is you take a 60 cc syringe, three-way stopcock, and so you have basically the bag, syringe, patient, and you turn off to the patient, you pull from the bag, turn off to the bag, and you pull to the patient. So it's basically turn, pull, turn, push, turn, pull, turn, push. So you're pulling from the bag, pushing to the patient. There's a couple of problems with this whole process, is that it's not so sanitary, in that a syringe was not made to do this multiple times, because you inevitably get the bacteria that's on the outside in. We in the emergency department have now moved to a new device called the LifeFlow. I'm not sure if you guys have heard of it. It's created by a guy I made friends with. He's an ICU doctor who basically now it's like a squeezy gun that's sterile. But there is no way of getting 20 cc's per kilo in quickly any other way except with push-pull or the LifeFlow. And so even if you have a 10, 12-minute transport and the kid's hypotensive, if you wait until you get to the emergency department, they will not be fast at it either, because guess what? They're not good at it either. So you owe it to the kid to get fluids in quickly. I would practice that if I were you. I can send you videos on that. I think I created a Antevy minute on it a little while back. I'll send you the link on it.
Yeah, we have practiced that, and that's what we teach here as well. But I just want to talking about when you said push pull, because I think sometimes we just call it the three-way stopcock method. Any other questions for Dr. Antevy? Last chance. The comments or the YouTube's a little behind us, so we have to give them a second. But what else is going on down there in Broward? Anything good?
With respect to pediatrics, I would say what we've done recently that I think for me is my next big push is just trying to learn how to talk to families on scene at a cardiac arrest, staying on scene. I'm kind of hell bent on trying to explain to people that the only way to stay on scene is to know what you're doing before you get there, and then to talk to mom and dad while you're on the scene, not in a kind of I'm so sorry thing, but really they want to know why are you still here? They're expecting you to leave the scene. You have to explain to them why you're not leaving, at least for the next 5 minutes or so. So if I had one big thing to ask everyone to do is talk to people on the scene, let them know why you're staying. And then I've tried to push my departments, and I got a lot of pushback, to call people after a death, call the families after a death, send someone from the department to a funeral, send a card within the year of the kid's death. And it doesn't make any sense. It's counterintuitive for a lot of people, but I'm really kind of convinced now that we have to do better when kids die. And so that's kind of like the other big thing for me that I want to really make people understand if I can. So.
Yeah, that's a great point. I remember when everybody was talking about in emergency medicine about keeping the family at the bedside while you were trying to resuscitate the kid, and how ill that was to have the family there, and how uncomfortable all the medical folks were with that. I think there's a lot of that when it comes to the pediatric codes. People are just uncomfortable being in the same room, having the parents right there while you're working on the kid with every other stressor with it. So it's not surprising to me that it's hard for us to change that practice, but we certainly have been working on it.
Yeah, well, I mean, I'll just make a shameless plug here that a few months ago I wrote this article, and it's this is a touching article for me because the guy on the right side of the screen there, his name is Adrian Castro, one of my EMS captains at Palm Beach County Fire Rescue. He actually did this on his own on a kid who got run over by the father. The father ran over the kid. There was brain matter on the floor. All of his crew, so the rescue and the engine who got there, wanted to only transport the kid. They wanted to avoid the parents and rush off the scene. And it turns out that when you ask 9 out of 10 EMS professionals, that's what they want to do. And it turns out that that's not the right thing to do, but this is a very hard topic. And so all I can say is that this requires some attention. It requires some practice. And the last thing I'll say is that I got a call from a guy in Alabama that I gave a lecture about in February. He called me up. He emailed me and I called him back because I was so impressed with the guy. He said he went onto a scene of a 16-year-old kid hung himself. He said never would he have ever talked to the family. He said that after they basically got this kid, they tried everything they could. He, for the first time, went and spoke to mom and dad. And he says, as hard as it was to do it, he recognized the unlock in him and how much better he felt about himself after the fact. And so it's counterintuitive, but it's life-saving for us as caregivers. And so I think we just have to learn how to do it, and then one day you just do it, right? And then you're a better person for it. So
awesome.
Yeah.
Tough stuff, but really important.
Yeah, it's tough. It is tough. Yeah.
Looks like we are just about out of time, and so I guess any last final comments? We have 2 topics coming up in CME over the next couple of weeks. One is how to work in your PPE and how to communicate with patients while you're wearing PPE, so you can still have a connection with them. And the other one is pediatric refreshers. Anything, any last pearls of wisdom you think we ought to touch on for our pediatric refreshers?
For pediatric refresher pearls of wisdom, I mean, I think that the concept, and I hope that I can come back and kind of talk more about this, but it's just a concept of closure on every call. And I guess what I mean by that is doing the right thing, even on the kid who's got the arm injury or the kid who's got abdominal pain. There's a way of kind of what I call getting to closure on those cases. And so we should really focus on treating every kid like we treat adults in that same kind of high level of care. And it's just another muscle that you have to use because I firmly believe now that how you treat every single patient, kid and adult, will really kind of show me the trajectory of your career. If you're going to be positive in your career after 30 years or not, all depends on a couple of things you can do on scene. Look at the parents in the eye, tell them that thank you. I'm glad that you called. Listen to the family member. Look at the kid. If they're old enough to understand you, ask the kid what their name is. Tell them your name. Some very small things. Pediatrics is not complicated. It's just that people just don't do it right. And so those are kind of the small pearls of wisdom that are so obvious. They're sitting right there under our fingertips. But just people just don't know what to do because they're so scared from the outset. So that's it.
Awesome. Thanks, Peter.
Yeah.
So I want to, again, thank you for coming. You've had a bazillion people in the comments who are saying they really enjoyed hearing from you and appreciate your time. And I certainly do as well. I appreciate you taking me up on my invitation to come chat with us today. I hope we can get you to do one of these again in a little bit. I know you're super busy over there with everything going on. Really,
and I'll come. If people want to keep hearing what my opinion, I mean, listen. At home, no one listens to me. On Zoom, they do. So I'm happy to do it.
It's great.
Yes, I'll be there.
Thank you for being here, and thank you for sharing all your information with us.
Anytime.
Take care, everybody.
All right, take care. All right, we good?